Hi, my name is Congresswoman Trahan. I'm here today with Dr. Baker, someone who I've gotten to know over the course of the last year. We're going to talk today about opioid addiction. This is a crisis that is a critical health epidemic that can't just be measured in numbers or statistics or dollars. It goes so far beyond that. It's almost too painful and too personal for us to describe. In the Commonwealth alone, 9 out of 10 drug overdoses are because of opioids. There is a working group of freshmen, a bipartisan working group of freshmen, focused solely on addiction because we want to use our collective urgency and our energy to address this issue. It is my honor and pleasure to bring you down to Washington to address this group who cannot wait to hear your perspective and some of your ideas for prescriptions moving forward. But I thought we'd take this time to talk about your personal story and what drove you to become such an effective advocate for opioid substance misuse.
Thank you, Congresswoman. I really appreciate your kindness in having me share what happened in my life and what brings me to try to work for change. I've shared before that I've been trained, or I am trained, as an emergency physician and an epidemiologist and a specialist in pain and palliative care, and now a hospice physician at Merrimack Valley Hospice up in your district where I work. And even with all that training and a long career in medicine, when my youngest son, Max Baker, fell into drug use, there was nothing that I knew to do to try to help him. And because as a physician, I know people in academia and who to reach out to try to find help. I was absolutely unsuccessful in finding anyone who could help him. And most people who become addicted to opioids at some point are going to ask for help. If that window of, Dad, can you help me, or whatever leads them to seek recovery tends to be very short. Mm-hmm. So when I took him to a detox center or a rehab center, to the emergency department, wherever we went, I could not find treatment for him. And within a couple of hours, withdrawal would start to set in and that window would close. Yep. So ultimately, I had to make the decision, which was the hardest one I ever made in my life. I thought that he may be dead one morning when I went into his room because I was making it easier for him to use and harder for him to stop by having a safe place to continue that. And I made the difficult decision to tell him, Mackie, you've got to go and you've got to go get treatment however it happens. I can't have you be here and let you die. And fortunately, he used that opportunity when he left that day to look for treatment and look hard, but he did find it. And within the first day, he was able to find a provider in Framingham who would treat him with medication-assisted therapy, and he started getting better. And within weeks to months, he was starting to be himself again. And he found a job. He enrolled in college. He fell in love with a young woman at UMass Lowell, where he was going to school, and his life was back on track. But then around Thanksgiving weekend actually, in 2016, he had a major car accident and required surgery for that. He told his physicians right up front, starting the night he was injured, I'm in recovery, I don't want opioids. Mm-hmm. And he stayed away from them until the morning of his surgery. And as part of surgical pre-op procedures, the anesthetist decided to give him an injection, she said, to help you help you relax. And she gave him an injection and wheeled him off to the operating room. And I asked, was that fentanyl? And she said, yes. And when he came out of the operating room, his eyes were glazed, and he said, Dad, I need medicine. I need real medicine. And his surgeon was shocked by this, and he thought we're going to get him through. Mm-hmm. But something had happened, and he reactivated those pathways in my best judgment, and within a few weeks of that day, he pawned his camera and bought heroin, and on December 28th, he was found dead on the bathroom floor. And I made the decision to honor his life and his efforts at recovery, to do what I could, whatever I could do, to help this from happening to other families.
Right.
And
yeah. Which is, I mean, it's what it makes you such an effective advocate, because when you first told me your story, it was so hard, you know, to hear. I knew the ending was going to be a bad one, because I knew about Mackie from my sister who introduced us. But there really were moments in the story where I had hope. In fact, you were the first person who I had ever encountered. And I have met with so many people who have, you know, served on the front lines of this crisis, have lost loved ones. But you were the first person who spoke so optimistically to me about medically assisted treatment and Suboxone, and you had seen what that had done for Max. You know, talk to me a little bit more about, you know, it's not readily available. People don't know that is an option that can really help the recovery. Of course, it has to be reinforced with, you know, recovery coaches and all sorts of services, right, to keep people on that path. But it is something that I think when you told me, it helped just decrease the cravings and that sort of primitive part of the brain that thinks in terms of survival mode and in having to get that, you know, that fix, if you will. So can you speak to us about how you found Suboxone, the journey that you all had to go on to get that kind of treatment?
I actually knew very little about Suboxone while my son was addicted. Mm-hmm. And I had heard the terms medication-assisted therapy, but honestly, on my own, I didn't really know much about it, and at that time, there were few physicians that were able to tell me about it, so it just wasn't something I was seeking out. He knew about it, okay. And that's what he was looking for. Who can help me with medication-assisted therapy? Yeah. And what happens in opioid addiction, whether it's heroin or prescription opioids, the receptors in your brain, they're actually pleasure centers, become occupied by those opioid molecules. Hmm. And initially, they induce a high or a euphoria or a sense that you're at peace and a good feeling. Yeah. And that lasts for a while. But then when you try to stop, and let's say you go several hours without using it, those receptors are calling out for more. Yeah. And that's what's driving an individual to seek that medication, to seek more of the opioid. Yeah. And I was with him. I remember so clearly one day he just was so determined to stop. Yeah. And he was up in his room and said, Dad, I'm just going to do it. And he was lying on his bed, and as the hours wore by, he started shaking. He was rolled up in a little ball. He was crying and moaning, rocking back and forth. And I held him and was caressing his hair, and I telling him, I love you, Mackie. I'm here, I'm here. And he fought as hard as he could, and there was nothing I could do for him. Yeah. And eventually he said, Dad, I got to go. And it's because those receptors are calling for that drug, and they override everything else. In his case, and I think in most people's case who are addicted, it's not a high that they're looking for. It's not some, oh, I want to feel good again, I want that first rush.
Yeah.
Most of the time it's they don't want to get sick.
Right.
And that is a powerful driver.
Yeah, it's a very physical driver, and one that, you know, it's, I think in the words that we use is that you can't get over this with willpower alone, because it is such a physiological, powerful, you know, feeling that, you know, that the patient ultimately needs to, you know, fix or end.
And that's correct. And I'm sure that there are people who have somehow been able to power their way through, and it happens when people are arrested and their supply of heroin stops, and they're not being treated with medications to control their withdrawal, and within 5 days or a week they have suffered through that withdrawal process and locked behind bars.
Yeah.
And it's a horrible process to go through, and they really fear that.
Yeah.
But Suboxone contains an agent called buprenorphine, and it's almost miraculous that that medication will occupy those exact same receptors.
Right.
The patient puts a little film tab under their tongue or in the side of their cheek. It's absorbed, and those molecules go right to those receptors and quiet them. You don't have withdrawal, you don't have cravings. In fact, when we give the medication to people, that's what the number one measure of effectiveness is. Are you feeling cravings, or do you feel okay?
Yeah.
And the patient feels normal again.
Wow.
They don't get high, they can think clearly, they can work, they can stay at home. And that medication is less than $10 a day, and the patient can start it within 12 hours or 1 day of their last use, and right then and there go on with their lives.
Yeah.
It may have to go on for months, years, maybe even the rest of their lives.
Yeah.
But while they're using that medication, they can function, think, behave rationally, work, take care of their families, and survive.
Right. Yeah. One of the other things that you spoke about early on when we first met was, here you are, you're a physician, and you have a son who's really struggling with addiction, and it caused you to flag for me that a lot of physicians don't have training, or they don't have the tools to identify addiction. And when you think about how important it is, whether it's the primary care visit or the emergency room visit, or whatever, at any inflection point where someone is seeking care, there's an opportunity to make that discussable, to take away the stigma and to talk about addiction. And I use the example to you, no matter whether I'm at my OBGYN or my primary care visit, the doctor is always asking me if I feel safe at home. And that is a question that I'm sure is born out of, you know, making domestic abuse or any physical abuse discussable while I am in their care. That was astounding to me, that we have this huge problem. Stigma is so much of it, because oftentimes people will not, you know, confront their addiction or seek the care that they need. And then on the flip side, we also don't have medical personnel who are conversant or proficient in, you know, getting at it when they're in their care. Can you speak a little bit about that? Because it seems like it's such a logical fix. In fact, we talk about it down here in terms of what we can do legislatively to make sure that we fix that. But talk to me about how physicians are trained today, and what we could do to fix that.
Well, because medical school curricula is set by organizations that monitor and determine what we all need to learn as physicians, there's a lot that we need to know, of course. Mm-hmm. So every radiologist has delivered a baby, and every one of us has worked in the emergency department. Every one of us has managed a trauma patient, and we also know about rare diseases like Kuru or Ebola, and we have to be trained in all these things.
Sure.
But when I went to medical school, there was zero training in substance use disorder or addiction, its recognition or its treatment. And now I still believe that most medical schools will talk about safe prescribing, that is being careful and judicious about what we're prescribing, but not teaching about how to recognize and treat addiction. And so as a result, 95% of physicians have no training in how to recognize or treat addiction. And in order to prescribe the drug we talked about, Suboxone, you need a federal waiver. You can't prescribe it unless you have that federal waiver. That takes 8 hours. It's free. It's online. You just sign up on a weekend that you're off, and you can do part of it one day and part of it the next. And at the conclusion of that 8-hour education, you take a test to verify you have learned it. Right then and there, you're given what's called an ex-DEA waiver, and that allows you to prescribe that treatment. And also know how and when to prescribe it, how and why it works, and to keep that patient safe. But for a variety of reasons, the vast majority of physicians have not taken that training and don't want to take that training. And so when you said, when I go to the doctor, I'm asked, do you feel safe at home? You might be asked, have you fallen? There's a variety of screening questions, but I don't think you've ever been asked, Ms. Trahan, are you or is anyone in your family suffering from addiction? And if they should ask that, and if you say yes, then the answer should be, let's help you. And even if that physician is not the one who helps you, he or she should refer you to someone right down the hall or in the same office that can help you. I remember going to my own doctor several times over several years, who I trust. He's very well trained, and I have great respect for him. And at the conclusion of our evaluation, he would kindly ask, Jim, is there anything else going on? And I said, yes, my youngest son is addicted, and every day of my life I'm in fear he's going to die. And I don't know what to do. And his response was, I hope he finds help. And he meant it. But unfortunately, he was unable to provide it himself. So that's the great opportunity of physicians to take care of the patients, the oath that we took.
Absolutely. And it has so far passed epidemic proportions. I mean, if you think back to the 70s and 80s, when we had the war on drugs, we were losing 5,000 people a year to drug overdose. Today it's 70,000. And that is all you need to hear in order to prioritize this in terms of what we do from a policy perspective and what we do on the ground in our communities in the way of education and awareness. While I have you, and I know we don't have much time, I mean, look, you lost Mackie, and there are so many families who share that pain, unfortunately. They have lost a loved one, despite all their love and their work to try to save them. What advice do you have for families who are going through addiction right now?
I hope that families remember that their loved one, underneath that addiction and the behaviors that go along with that, they're still the person you love. If it's your son and his behaviors change, and money disappears from your wallet, or he gets arrested and he can't help it, underneath that addiction is still your son who you love, and he's still there. And once that addiction is brought under control, he'll emerge again. So please keep loving your child. Know that, Have him know that you're there for him, and find a way to seek treatment, because one night at 3 o'clock in the morning you may tap on the door and say, "Mom, I'm ready to stop," and you need to know where to turn.
Yeah.
And also, if you have a son or a daughter, a family member who's still using, have Narcan in the house. Have one in this pocket and one in that pocket. And I tell people, keep a sledgehammer under the bed. If you hear a thud in the bathroom, something's not right. You need to get in there and fast. It's just like your baby's underwater. They're not breathing. Take that hammer and bash that handle and bash that hinge. Go in there and give them Narcan, because every second counts.
Yeah.
And I think that step number one is to save your child, keep your child alive, find an avenue to treatment, and keep on loving them.
Yeah. Thank you. Dr. Baker, you have so much influenced, the way I approach this epidemic and the levers that I know that I need to pull on as a legislator. And I really do thank you for sharing your story with me with all the urgency that it deserves. And then for also coming down and sharing your story with all of my colleagues, my staff, and just giving us very thoughtful prescriptions on how we should move forward. I really appreciate your advocacy and the love for your son.
Thank you, Congresswoman. And I want to say that I respect your authority and capacity to lead us forward, and our responsibility as physicians to help you and guide you with medical knowledge and science so that we can succeed.
Thank you. Thank you.